Okay, picture this. A pregnancy seems to be going smoothly, everything on track, and then often, quite unexpectedly, things can take a sudden, really serious turn.
Hmm. It's a situation that clinicians approach with intense focus, precisely because of how rapidly it can develop and its potential severity.
Absolutely. And that critical condition is what we're diving into today. Welcome to the deep dive.
Hello.
We take a stack of sources, in this case, it's really detailed revision notes, and we pull out the most important, kind of high-impact information for you.
Yeah, think of these notes as a concentrated summary, really essential knowledge. Our mission today is to navigate them together and distill the absolute core insights you need to quickly get a solid understanding of eclampsia.
Right, we're sort of cutting through the noise to get to those high-yield points, almost like a guided, super efficient study session.
Exactly.
So let's crack these notes open and jump straight in. The notes start, interestingly, not just with eclampsia itself, but its precursor.
That's right. You really can't talk about eclampsia without understanding preeclampsia first. The notes define preeclampsia as a hypertensive disorder developing during pregnancy. Crucially, it happens after 20 weeks of gestation.
After 20 weeks,
Yeah.
okay. And what are the hallmark signs the notes highlight for preeclampsia?
Well, the two main ones are high blood pressure, specifically noted as readings over 1490 millimilli Hg,
Okay.
and signs of damage to other organ systems. The most common sign the notes point to is proteinuria. That means excess protein in the urine.
Oh, right, proteinuria.
Yeah, and they give a threshold for this, over 300 milligrams in a 24-hour urine collection. That's the specific value mentioned.
Okay, so preeclampsia equals high BP over 1490 after 20 weeks, plus evidence of organ damage, usually that protein in the urine. That makes sense as the foundation.
Mm-hmm.
So then, what is eclampsia? How do the notes define that?
So eclampsia is when preeclampsia escalates. The defining feature, according to these notes, is the occurrence of seizures or even coma in a woman who already meets the criteria for preeclampsia. That seizure component is the critical step that distinguishes it.
Got it. So it's preeclampsia plus seizures. That's a really clear distinction the notes make.
Right.
But why does this happen? The notes mention the cause is, well, a bit uncertain.
They do. The precise underlying trigger isn't fully understood, but the notes strongly link it to abnormal development and function of the placenta, usually early in the pregnancy.
The placenta,
Yeah.
the organ supporting the baby. So something going wrong there is thought to be the root problem that then impacts the mother.
That's the leading theory the notes emphasize, yes. If the placenta doesn't develop correctly or maybe implanted improperly, it can lead to disruptions in blood flow and the release of certain substances that affect the mother's vascular system.
Huh. Fascinating that the problem originates there. Okay, given that suspected link to the placenta, who is most vulnerable? Who is at higher risk, according to these notes? This seems like crucial knowledge for identifying potential issues early.
Absolutely. Recognizing risk factors is key. The notes highlight several important ones. Being in your first pregnancy is listed as increasing the risk.
First-timers, okay. That's a key group to be aware of them.
Yes. And a history of preeclampsia in a previous pregnancy, that's a very strong predictor.
Right, if you've had it before.
Exactly. If someone has had it before, the notes indicate a significantly higher chance of it happening again.
Okay, first pregnancy and a history of preeclampsia are major flags. What else do the notes list?
Existing chronic health conditions like hypertension or kidney disease increase the risk.
Makes sense.
Obesity is also noted. And carrying multiple babies, like twins or triplets. Multiple gestations.
So underlying health issues, a personal history, and the specifics of the current pregnancy first one. Multiples can all contribute to someone being more susceptible. That's a really valuable set of points from the notes for identifying high-risk individuals.
It allows healthcare providers to be more vigilant, doesn't it, with monitoring for these specific groups.
Let's dig a little deeper into how this happens. The notes touch on the pathophysiology. You know, how that abnormal placenta leads to the widespread problems in the mother's body.
They simplify it quite well, actually, stating that substances released from this abnormal placenta circulate in the mother's bloodstream and essentially disrupt blood vessel function everywhere.
So, like bad signals from the placenta messing with the body's plumbing, kind of.
A bit like that, yeah. These substances cause the blood vessels to become leaky and constricted. The notes mention the underlying processes include endothelial dysfunction.
Which is damage to the lining of the blood vessels.
Exactly, damage or improper function of that inner lining, as well as inflammation and oxidative stress. Those are the mechanisms cited.
Okay, so the placenta sends signals that essentially damage the blood vessel walls, leading to tightening inflammation throughout the body, which then manifests as the high blood pressure and organ damage. That helps clarify the chain of events the notes describe.
Yeah, it provides the biological basis for the symptoms we actually see. Now, while we've said seizures define eclampsia, it's important, as the notes point out, that seizures in pregnancy aren't always eclampsia.
Right, good point. So when someone has a seizure while pregnant, doctors have to consider other possibilities. The notes give a list of other things it could be a differential diagnosis.
Exactly. They need to rule out these other causes. The notes list conditions like pre-existing epilepsy or other known seizure disorders the woman might have had before pregnancy.
That makes sense. If she had a seizure disorder before, it might just be her underlying condition acting up.
Precisely. Other possibilities from the notes include seizures caused by bleeding in the brain, cerebral hemorrhage, or infections affecting the brain.
Also very serious conditions, but distinct from eclampsia's cause.
Yes. Also listed are hypoglycemia, so very low blood sugar, certain types of severe migraine, particularly those with aura, which can sometimes mimic neurological events,
Oh, interesting.
and seizures triggered by certain drugs, drug-induced seizures.
That's a crucial reminder from the notes. A seizure in pregnancy requires a thorough workup. It's not automatically eclampsia. It's about going through that checklist of possibilities.
It really underscores the complexity of diagnosis sometimes.
How common is eclampsia? Is this something seen frequently in maternity wards?
The notes give specific figures, and they state it's rare in developed countries.
Okay, that's good context. Less common than pre-eclampsia, which itself isn't universal.
Yes. And they provide the UK incidence specifically, which is about 1 in 2,000 to 3,000 pregnancies.
1 in 2 to 3,000. So it's not something the average person encounters or even, the average clinician sees every day, but it's frequent enough that every maternity team needs to be fully prepared for it.
Absolutely.
It's rare, but incredibly impactful when it occurs.
Precisely. Low incidence, high stakes.
So putting it all together, what does eclampsia look like in a patient? Beyond the seizure, what are the key clinical features the notes say to watch for?
Well, the primary feature, as we've established, is the seizure itself. The notes describe the typical type as generalized tonic-clonic seizures, what people often think of as grand mal seizure.
Okay, the classic shaking seizure.
Right. However, they add the important detail that other seizure types can occur, so it's not always that classic presentation.
Good to know. And the underlying preeclampsia signs are almost always present, right? By definition.
By definition, yes. The notes reiterate those key preeclampsia signs. Elevated blood pressure, again specified as above other 40-90 millimilli sustained after 20 wints.
Right?
And that proteinuria we mentioned.
Protein in the urine, yeah.
Exactly. Excess protein, often over that 300 milligrams and 24 hours threshold. The seizure occurs in the context of these findings.
Are there other symptoms or warning signs someone might notice before a seizure happens?
The notes list several common associated symptoms. Severe persistent headaches are frequently seen.
Not just a typical pregnancy ache, but really intense.
Right. Also, visual disturbances are highlighted, things like blurred vision, seeing flashing lights or spots, floaters, or even temporary loss of vision.
Flashing lights or spots, that's a specific symptom from the notes that feels particularly high yield for recall.
They are, definitely. Upper right side abdominal pain is another symptom listed, which can sometimes indicate liver involvement.
Okay.
And generalized swelling or edema, particularly noticeable in the hands, face, or legs.
So if someone presents with high BP and protein, and then develops severe headache, visual changes like those flashing lights, upper abdominal pain, or swelling, that constellation of symptoms, especially leading up to or alongside a seizure, points strongly to preeclampsia progressing to eclampsia. The notes really lay out that cluster of signs.
It gives clinicians a pretty clear picture of what to look for, yeah.
How do doctors confirm the diagnosis then, and figure out how severe the impact is on the body? What investigations do the notes say are essential?
The notes list the crucial tests. First and foremost, simply measuring and monitoring blood pressure regularly.
Basic, but vital.
Yes. And urine analysis to check for the presence and amount of proteinuria.
Confirming that organ damage component of preeclampsia we talked about.
Exactly. Blood tests are also essential. The notes specify checking markers of organ function, particularly the liver and kidneys, to assess the extent of damage.
Right.
They also mention checking blood clotting factors, as this can sometimes be affected.
So blood tests to check the mother's internal systems. What about the baby? Is there monitoring for the baby?
Oh, yes. Fetal monitoring is critical. The notes indicate tests like ultrasound and monitoring the baby's heart rate to check on their well-being. because the condition affects both mother and baby.
So the investigations are about confirming the diagnosis, assessing the damage, and checking on the fetus. It's a comprehensive picture needed to make urgent decisions.
They provide the data needed to guide the immediate management plan, which the notes detail quite specifically, particularly in the UK context.
Okay, management. What's the absolute core strategy once eclampsia occurs? What's the definitive treatment highlighted in the notes?
The notes stress urgency and state that immediate delivery is the definitive treatment, regardless of how far along the pregnancy is.
Immediate delivery. So deliver the baby and the placenta as quickly as is safely possible.
Yes. The removal of the placenta is considered the way to address the underlying cause of the condition, which, again, reinforces the idea that the placenta is central to the problem.
That makes sense. Get the problematic organ out. What about medication? Magnesium sulfate is mentioned prominently, right?
Absolutely. Magnesium sulfate is a cornerstone of treatment. The notes emphasize its dual role. It's used both to prevent seizures in women with severe pre-eclampsia and to treat active seizures in eclampsia.
Prevent and treat. That's a really important detail to remember about mag sulfate's function.
It is. And the notes provide the specific protocol for administration, which is a key detail for revision. An initial intravenous bolus, a quick, larger dose, followed by a continuous IV infusion.
Bolus, then infusion. Got it. While someone is on magnesium sulfate, the notes stress very close monitoring. What are they watching for?
Monitoring is vital, yeah, to ensure the patient is responding and to watch for signs of magnesium toxicity. The notes list specific parameters, urine output.
To make sure they're excreting the magnesium properly and not getting fluid overloaded.
Correct. Also, checking deep tendon reflexes, diminished or absent reflexes, are a sign of potential toxicity.
Wow.
Respiratory rate and oxygen saturation are also closely monitored.
Because high magnesium levels can suppress breathing. Is that the worry?
Exactly. The notes explicitly caution about the risk of respiratory depression.
And if that happens, is there an antidote? Do the notes mention one?
Yes, the notes clearly state that calcium gluconate is the specific antidote used to reverse the effects of magnesium toxicity, like that respiratory depression.
Calcium gluconate, the antidote for magnesium toxicity. That's another critical high-yield fact from the notes.
Yeah.
Okay. How long do they continue the magnesium sulfate treatment?
The notes specify continuing the infusion for 24 hours after the last seizure or 24 hours post-delivery, whichever happens latest.
Okay, so it continues for a full day, even after the immediate crisis or delivery. What else is part of the management plan? Anything else key?
Well, controlling the mother's blood pressure with appropriate medications is essential. And general supportive care, including careful management of fluids and electrolytes.
Careful fluid management. The notes have a specific caution there, don't they? I remember reading that.
They do. There's a strong emphasis on fluid restriction to avoid complications from fluid overload, given how the condition affects blood vessels and fluid balance.
Right. The body isn't handling fluids normally because of the blood vessel damage. So the management is really multi-pronged. Urgent delivery, the specific mag sulfate protocol with careful monitoring and knowing the antidote, controlling BP and strict fluid management. It's clearly focused on stabilizing the mother and getting the baby out safely.
It's a critical cascade of interventions, really, and the effectiveness of those prompt actions directly impacts the outcome.
Speaking of outcome, what's the prognosis like, according to the notes, if it's managed well?
The notes state that with prompt and appropriate intervention, the prognosis is generally favorable, which highlights why early recognition and rapid treatment are so crucial. They significantly improve the chances of a good outcome for both mother and baby.
So quick action makes a big difference. What are the risks if eclampsia isn't treated quickly, or if it's severe?
Untreated eclampsia carries significant risks, yeah. The notes list serious potential complications for both mother and baby. For the mother, this includes severe organ damage, potentially affecting the liver, kidneys, brain, and the cardiovascular system. There's also the risk of stroke.
Very serious. And for the baby, what are the risks there?
Risks include placental abruption. That's where the placenta separates from the uterus too early, which is very dangerous for the baby because it compromises oxygen supply.
Right.
Preterm birth is highly likely, often a direct consequence of needing immediate delivery to manage the eclampsia. And fetal growth restriction can be a complication, especially if the underlying preeclampsia has affected placental function over time.
And sadly, the notes mention maternal mortality is still a risk, although significantly reduced with modern management.
Yes, it's a reminder of the potential severity, even if it's rare now in developed settings. So while prompt intervention is usually successful, that list of potential complications really underscores why eclampsia is such a feared condition. It impacts almost every system and the pregnancy itself.
Wow. Okay, that was a thorough deep dive into eclampsia, working directly from those detailed revision notes. We've covered everything from what it is, why it happens, who's at risk, how it affects the body, what it looks like, how doctors check for it, the urgent management plan, and the potential outcomes.
Yeah, we've really aimed to pull out those absolute high-yield points that the notes are designed to convey, giving you a really focused overview for revision or just, a solid understanding.
Hopefully this breakdown helps clarify the condition and serves as a really efficient way to absorb this critical information. If you're using resources like these notes for medical revision, maybe for the MSRA, and found this helpful, you might find more materials like this over at pastthemsra.com.
And also at freemsra.com, both good resources.
Navigating complex medical topics like this can be challenging, but understanding the key details, like the ones we pulled from these notes today, is incredibly important.
Indeed. And, thinking about that initial point we discussed about the uncertain cause being linked to placental development, it does raise a fascinating question, doesn't it?
What do you mean? Where are you going with that?
Well, if the problem really starts at the placenta very early on, perhaps even before any symptoms appear, what does that suggest about the future? Could advancements in identifying these placental issues much, much earlier in pregnancy fundamentally change how we manage this risk?
Ah, I see.
Could we potentially intervene earlier to prevent it from ever reaching the stage of pre-eclampsia or eclampsia in the first place?
That's a powerful thought. Shifting from treating a crisis, which is what we've mostly discussed, to actually preventing it at the source entirely. Research into early markers or maybe supporting placental health somehow. That could be truly groundbreaking.
It highlights the ongoing evolution of our understanding of these conditions, I think. Always more to learn.
Absolutely. Something to keep in mind as the science progresses.
Definitely.
Thanks for joining us on this deep dive.